right on time at 3 p.m. Eastern. All right, we are going to get things started. Thanks everybody for joining us. Again, I'm Bill Newman with Group Dentistry Now. Appreciate you being here today. Let me go back to that main slide, just so anybody that came in late. This is the DSO Study Club. We're going to spend the next hour talking about the importance of dental in the growth of integrated healthcare models. We have two panelists. They're going to take us through this journey, where we are as an industry, where it's going, a lot of really important questions. What does it mean? What is integrated healthcare? So we have Dr. Huong Lee. She is the Chief Dental Officer of Asian Health Services. And we, of course, have Andrea Hight from Henry Schein One. So I'm going to let Dr. Lee introduce herself because she knows her background better than I do. But Dr. Lee, thanks for being here today.
Okay, well, thank you so much, Bill. I hope you all can hear me fine.
Excellent.
Yeah, my bio is actually on the screen, so you can read it. I'm not going to read it, but just a little background about myself. I was born and raised in Vietnam. I came here at the age of 17. So I attended college and dental school here in the United States. I was in private practice after after graduation from dental school. Actually, I did a GPR program. Then I went into private practice after that. I entered the community health center setting back in 1989. So I've been with public health for about 32 years now. And I'm just hoping that through this webinar that I'll be able to share with you some of the practice models that we are doing at Asian Health Services. So thank you again for the opportunity, and thank you for attending the webinar.
Thank you, Dr. Lee. Andrea.
Thank you, Bill. I was born in Tasmania, Australia, which is where I started my career in dental public health with the Tasmanian Health Department. And everybody makes Tasmanian devil jokes, so we'll move on from that. But I married an American, switching countries, and here I am in the United States, and continued a career in dental, both in public health as a dental director for the Utah State Health Department for a number of years, and since then with Henry Schein. And Henry Schein has given me the opportunity to be involved in a number of national initiatives, sit on boards, and actually sit on boards along with my friend Huong Lee here, and be very much involved in the impacts and the direction of what dental health is doing and where it's going in the United States.
Great, thank you, Andrea. So those are the introductions, and now we're going to start to talk about integrated care and what does that mean. And so we'll let Dr. Lee start off here with this slide. And again, what we'll do is we'll talk through a couple of slides here just to kind of build out a basis for the rest of the webinar. Again, we had a lot of great questions. We're going to answer a lot of those here. And then last 30 minutes or so, we're really going to get into a panel discussion. And again, like I said, we had about 35 really, really good questions. We tried to whittle it down to about a dozen, but we want to make sure we address those. And then also, if you have any questions, I think we're all used to Zoom at this point. During the pandemic, we all got very comfortable with it. So feel free to ask some questions in the question area. So Dr. Lee, please start.
Okay, so before we talk about integrated records, we really need to talk about what's going on in the healthcare environment that necessitates the need for integrated records, and that is integrated care. And in my mind, I work in the community health setting that really has allowed me to work very closely with my medical counterparts. I'm the Chief Dental Officer of Asian Health Services. On the medical side, we have a Chief Medical Officer who provides oversight of the medical, of the whole medical operation. And we work very closely together to make sure that our patients are treated as a whole person. And what I mean by a whole person is that we take care of our patients, the body, the mouth, and the mind. And what I mean by that is like, I work with the physicians, and I also work with the behavioral health, departments. Integrated care, in my opinion, is really a system where we can provide a seamless, effective, efficient care to meet our patients' health needs. And instead of just treating the dental symptoms or health diseases, we need to really shift our focus to to treating the whole body, because our patients have other underlying medical conditions that may affect our decision in what treatment we should be providing, to our patients. So that's sort of, where I'm coming from. Also focusing on the whole body, instead of just the few aspects, such as just dental disease, will help us create a much more, I would say, well-rounded treatment approach for our patients. But in order for us to be successful at doing that, there needs to be communication between us dental providers and medical providers. And that's where integrated healthcare records become very important, so that everyone, on the healthcare team, physicians, dental providers, specialty mental health, allied healthcare personnel, can communicate in real life, in real time. So that's really, how I see the need for us to be discussing the integrated care, and also why we need to have integrated records. So at this point in time, I'm going to transfer. I'm going to give the mic to Andrea so she can talk more about the integrated records.
Well, I'm going to talk a little bit more about what you said, and then perhaps talk more where DSOs fit into this. But yes, we look at what drives integrated care, and as Huong articulated, of course, we've got to treat the person as a whole. Everything is connected, and so one part of the body impacts the other. We look at that and we see how the cost of healthcare in the United States is impacted. For instance, 50% of adults have chronic illnesses, the most prevalent of which are diabetes and hypertension. The cost of treating these chronic illnesses a year is in the range of $153 billion. Along with that, the federal government picks up a huge amount of that cost, because 77 million people are on Medicaid and receive Medicaid health benefits. So we start looking at the fact that healthcare is very expensive, and non-integrated models don't make patients as healthy as integrated models do. And there is already research from a number of different sources, whether it's the National Institute for Health here in the United States or other countries such as Great Britain, that demonstrate that very, very effectively. So there's that underlying driver to integrated care being good for the patient. It's good for the cost of delivery of care, and it's good for providers because they're really making a difference in the most appropriate way.
Mm-hmm. And
so,
also, I'm sorry,
yeah.
Go ahead. Go ahead.
ahead.
No, I was going to say also, I didn't mean to interrupt you, Andrea. I also want to say that our patient population is becoming aging. We have a much higher, percentage of seniors in our patient population at this time who will come into our offices with multiple medical conditions. So this is where I think that knowing, the medical conditions is very important, in the clinical decision making process. So, okay, I'm sorry. Yeah.
No,
Let's go back to Andrea.
That's a really important point, because I'm sure there are dentists listening today who have dealt with a patient who's forgotten to tell them about a medical condition or a medication, and they've gone ahead with treatment and then realized they would have handled that patient completely differently if the patient had been a better historian about what that background is. So one of the immediate benefits to care that is integrated with interoperability of information is that it's going to be safer care, and you're going to be able to make better treatment decisions in better context. So now what do we look at? You know, the question here is, what does this mean to DSOs in the future? Well, integrated care is primarily occurring in community health centers, public health, and public and hospital networks. We're seeing it, especially growing hospital networks now. And while it's happening there, one of the needs of all of these networks is more oral health access. They've got to have dental. When you look at community health centers, typically there is only one dental facility for every 4 medical facilities. So there isn't enough access. So now we look at DSOs, and DSOs are very well positioned to work with in partnership other primary care models. Firstly, you tend to have multiple sites. You're already looking at centralized electronic records so that you can effectively manage across multiple sites, whether it's patient care, productivity, compliance, or whatever it is. So really well positioned to become a partner with a primary care delivery model. And of course, the next question is cost effectiveness. Really, when you look at the role of the dental provider, the fact is patients are more likely to see you once or twice a year, as opposed to their physician. They might not see their physician every year. And when you engage with the patient, it's actually for a longer period of time. When you're providing dental care, it's more than just the 10 minutes I last spent with my physician on my care. It's much longer. It gives you the opportunity to really engage effectively with the patients and to be able to identify what is going on with them that might not be caught elsewhere. This means that there are additional services that you can provide that have very real meaning. Now, some of those are very much limited by practice acts, which vary from state to state. And some of them are also dictated by what insurances will cover and whether an overall insurance will pay for certain services to happen in a dental clinic. But you've got an example with what happened here in California recently with A1Cs. Do you want to share that? Because that's an important example.
Yeah, so we were very fortunate that, we were able to start a diabetes screening of all of our patients. And and basically we use the American Diabetes Association, diabetes survey that you can download. It's free. You can download it. And then, so we have all of our patients that come in, fill out that form. And if they score a 5, it goes from 0 to 10. And if they score a 5, then we offer to the patients the hemoglobin A1C tests. And we conduct that test right in the office. And the reason for that was that, we do see a lot of low income patients. And also we have, most community health centers probably have about anywhere from 9 to 11% seniors. At Asian Health Services, we have 22% geriatric patients in our patient population. So when we start doing these, the screening, we found that a lot of our patients are actually 5 and above. So we conducted the hemoglobin A1C, and we were able to identify a lot of the patients whose hemoglobin A1C would put them in the diabetic condition status. And because of that, we were able to refer them to their physician, for further workup, because we don't diagnose, we basically just do the screening test, and that's what we tell our patients. We had one case where a 19-year-old that was scheduled for surgery, and when our oral surgeon did the hemoglobin A1C, his hemoglobin was at 12 points. So he's completely his diabetic condition was completely uncontrolled. And we referred him to his pediatrician, who then referred him to endocrinologist. Now, this patient would not have been under the care of the endocrinologist if we had not done the hemoglobin A1C test in the dental clinic and made the appropriate referral to his pediatrician. So there is a value to that, to some of these screenings.
And so building on that, there are a number of things that you can do in the dental environment, once again, depending on practice accent and so on, that really actually very much belong in dental treatment. Han just gave a good example that we both have a mutual friend who some years ago went to her physician complaining about difficulty swallowing. Her throat felt swollen. She was told, oh, it's allergies, After multiple visits to her physician and not feeling like she had answers, she went to her dentist, who immediately realized there was a growth. And she ended up being diagnosed with stage 4 throat and tonsillar cancer. The good news is treatment worked on her, but she only had a 20% survival rate. Now, this is something where dentists have such a different perspective when they're looking at oral tissues, that really her dentist saved her life. So as we look at some of these, taking weight, BMI, taking blood pressure, can be a really simple foundation to identifying areas where a patient may need to be referred, or you may have concerns about continuing with your dental treatment. Of course, oral cancer, as I just mentioned, osteoporosis, doing screening with a Panorex or with 3D cone beam can be very valuable. And of course, TMJ and sleep apnea, a number of you are probably addressing those things as well. So there are really a variety of activities that are very holistic, that support overall health, where the dental clinician can really provide so much more perspective and understanding and make referrals. There's already research that indicates when a patient is screened in the dental clinic for a problem like this, they have about a 55% compliance in getting to their private, to their physician for care, which is actually pretty good. So do we want to move on, or?
Yeah, that actually is great. I've got actually 2 questions already that came in. One I think we should probably address now because it relates to the previous slide. You're talking about, Dr. Lee, about the HbA1c test. Do you submit to get reimbursed to medical insurance for that test? How does that work? Or Andrea, either one you can answer.
Yes, so we do submit the hemoglobin A1C test to a medical insurance. A lot of our patients are actually Medicaid patients, and there is a code that we could use, to submit for our payments.
Great. And then I do have another question. We're going to hold this one because it actually ties into something we're going to discuss later. So we'll take over here with the interfaced electronic health record.
Well, we talked before about the fact that patients aren't always the best historians. So one of the foundations for integrated care is interoperability of health records, which means quite simply, we need medical records to talk to dental records and dental records to talk to medical records. And it's actually a good time now to consider the direction. It's not that total integrated care is going to happen in the next year or two, but it is definitely on its way. And as we plan for what our practice management software should do, planning for the future, especially if we're planning to grow, we want a record that's going to be a solid centralized record with enterprise capabilities so that the dental operations themselves are more effective. You want centralized administration, centralized billing, anything else where you can reduce the ratio of administrative salaries to clinical salaries, because it's the clinical that provides the care and it's the clinical that generates the revenue. So we want to start with those efficiencies within the DSO, and then build on that with software that is going to be able to talk to and from an electronic health record. So there are some important considerations we see in the industry already. And one of those that we see in integrated models, such as community health or even hospital models, is that there are times when the dental program is really forced into a medical software. And to me, it's kind of like Cinderella and the glass slipper. You know, the glass slipper fit Cinderella perfectly, but when her stepsisters tried to fit it on, it pinged off and flew across the room. It's the same thing with the software. The software needs to fit what you're doing. And I don't need to tell you that you've got very specific requirements, both as dental clinicians, dental administrators, to be able to do your jobs well, efficiently, with less stress, with compliance, with risk management in place. So it's important for a dental support organization or private practice to have a software that supports what they're doing, and for the medical delivery model to have a software that supports what they're doing and the way they do it, and then have the ability to talk. So when we're talking about what interoperability should do, we want to start with an open architecture that allows that free exchange of information. We want to be able to identify a patient as a unique patient. Whether they're in medical or dental, we identify them as the same patient. We want their diagnoses, their medical problems, their prescriptions, their allergies to populate the dental software, so there's no doubt about what's going on. And we want the treatment that the dentist has provided to also go back to the medical provider. Medical providers in the past thought, well, do we really need it? But those that get that information discover that there is a wealth of support for what they need, especially if you're looking at the link, as we all know, between perio disease and systemic diseases. Then we want to take it additionally, and Huong gave an example of if there are tests or vaccinations that are due, why can those not be done in the dental environment? Why should a patient go back to a medical provider if they're already there in a dental clinic? Once again, Practice Acts and insurance will be making some changes, but that's really one of those questions. It's like, if you've got a captive audience and there's something that they need, such as, well, right now, a COVID vaccination, why not be able to do that while they're there for their dental appointment? And then it can be sharing of lab work. You know, when labs are drawn in the medical environment, knowing what those results are for dental can be very insightful, once again, for the kind of dental care that is provided, along with being able to reinforce what that patient should be doing to take care of themselves. So lab work comes back and says, you know, you've got high cholesterol. You see that it's an opportunity for your hygienist or you to discuss what they're doing about their diet and exercise to help address that. So this is where we start to see the interoperability of the health records supporting ease, efficiency, and accuracy in providing care in a cost-effective manner and in a more impactful manner that makes the patients healthier. And so those are really examples of what we want to see as the essentials of interoperability. Huong, do you have some thoughts on that?
You know, yeah, so, you know, I think that EHR integration in healthcare is very, very critical. We, you know, my medical side uses a totally different EMR system, and I use a dental system, but we're able to get the interface to work between the two systems. And not only that, they switched to another system after we already got it all integrated, and like 5 years later, they decided to go onto something else. So then but we were able to establish that same bridge. So our demographic information, is being shared, billing is being shared, and also we can access any, medical record on the patient. We can see lab values, we can see the problem list, we can see medications, and it's really important for us, to be able to do that. And when we make referrals, we could actually see who's making referrals to us and who we are referring to, and that way we can close the loops. So and we see, like I said, we can see the medications the patient's on. And sometimes patients are not really the best, historian of their health, conditions. In the past, before our medical side, got on electronic health record, what we had to do was we asked our patient to bring in the bag of the medications, and they would bring in a grocery bag, of medications. But now that it's all interfaced, we're able just to get, lock on their chart, and we would know, what they have, in their pharmacy, I guess, in their own pharmacy, walking pharmacy, I call it. And also, it really helps, us to be able to communicate, much faster. And it also forces us, medical and dental providers, to work together. We have to interact, because if I'm sending, a message to my medical providers will have to send back, the answer, and vice versa. So we do the same thing. And I'd say, our patients' satisfaction has increased because of that communication. Because when I talk to my patients, I know the medications they're on. I know the problem list, so I can really articulate and communicate with my patient much better, because I do know, what they're going through. So, and there are different models, there are different ways, to integrate. And so it all depends on what you want to do and what the medical, counterparts want to do. But that interface is really, really important. I mean, most of us probably can't remember the last time we went to our doctor only to find out that the lab orders hadn't arrived yet, right? So the doctors didn't really know what our lab values were. And maybe you also switch your physician, your provider, and you probably recall what the challenge was, to move your medical records from one practice to another. So now with the integrated record, I think that has alleviated a lot of these challenges. Yes, getting a good system, a good bridge, is really important, and it helps us to provide much better care to our patients, and we have much better patient satisfaction survey. Patient satisfaction.
Yeah. And I was just thinking about the fact that there are some additional drivers for interoperability. For instance, states are starting to set up health information exchanges.
Yes.
So if you're a provider who is treating Medicaid or Medicare, there are now in certain states becoming requirements that you've got to be able to share your information on a health information exchange, which is all part of this creating interoperability, so that no matter who the provider is, you've got access to this key information for continuity of care. So I think we're going to see that as a driver in the not too distant future as well, given that there are already several states going that direction.
Great. So let's address this question here, and then we can actually, I believe we can move on to the Q&A section here. Let me do this. Let's stop the screen share. We're going to, well, hold on. That signals we're moving on to the questions. Okay, now we're going to actually stop the screen share so you can actually see us and not just the PowerPoint presentation. So we do have a question that was addressed, but I want to make sure that we addressed it for Nathan, who was the person that asked the question. So you talked a little bit about, the integration of practice management softwares. How do they talk to each other? You've got things going on the medical side. You have things going on with Dentrix, right? So how does that all work? And are you seeing like a tighter integration of the dental practice management software, which is one of the questions we had, and then also with some of the medical records?
You know, that's such an important question because we need to see improvements in this area. When you're dealing with, say, a dental record and health record, they both have to talk to each other. It's like, let's take the dental record. The dental record may be perfectly able to talk to the medical record, but if the medical record refuses to accept the message, even though it can, then it doesn't matter how capable the dental software is. So I'll speak in terms of Dentrix Enterprise. Dentrix Enterprise uses what's called HL7, Health Level 7. That is an international standard for how information is shared commonly right now between health and medical records. We can do a whole bunch of different messages, but depending on the electronic medical record and what they will do, there are some medical records where we interface completely and others where it's only 2 or 3 different messages. So it's got to be, both sides have got to talk to each other, which is why I was saying one of the things we want to see, and not just for my company, but really across the industry, is open architecture. We need not to have software companies of any kind creating pseudo barriers in the name of income in preventing communication across healthcare records. It really needs to be open and complete and allow choice. Like I said, dental providers need to choose the software that is appropriate for them, medical software that is appropriate for them, and not have to worry about whether or not those two will exchange information. Did that answer the question? Or
yeah. I also think that, you know, HL7 has been out for a long time, you know, for decades. And I, you know, it may be the time for the government to come in and say, hey, every health record, in fact, I believe it may already be on the book. It's just that it's not being enforced. And that is, every health record has to be able to talk to each other, so that one cannot say, nope, I don't want to accept your messages. Nope, you're not on my platform, and therefore, no, we don't want to talk to you. I think that that needs to be some efficacy efforts to say that HL7 is here and that it has to be made available so that, you know, providers can talk to each other regardless of which program they're on.
exactly.
Great point. So here are some of the questions again that came from the registrants, and again had a lot of them. So we're going to try and hit the ones that we felt we could answer. There were a lot of duplicates. So a great question here. Other than academic settings and FQHCs, where are you seeing integrated care being practiced? So that's number one. Like where beyond where you would traditionally think you would see it. I'd love to hear some thoughts, you know, from, you know, Dr. Lee, what you see, and then Andrea, as you travel around and you talk to different providers, you know, kind of what you're seeing out there. Might be pretty creative, because I think the audience, from what I gather, but based on the questions, it's a lot of interest in this integration, but they don't necessarily know, where do we start? How do we go about it? What does it look like?
You know, I see also, you know, in the Q&A, there's also a question that's similar, you know, to what you just proposed. And that is, yes, in private practice, it's probably a little bit more difficult, but not impossible. I do think that, you know, I was in private practice, you know, at one point in time. And of course, this was years ago when integration of healthcare was not even a topic. But I do have, you know, colleagues who are in private practices at this time. They and I agree with you know, with Kathleen, who put in the Q&A, you know, section, that the physicians are usually not paying attention, you know, to dental, you know, even screening. Many of them But I have to say that the newer generation of medical providers, I believe, is much more in tune with the integrated healthcare. The ones that have been practicing for a long time probably are not, you know. And unfortunately, medical education only has about 2 hours on dentistry in their academic curriculum. you know, and I know that because one of my children is a physician, and he's an ENT too. So what does he know about dentistry? Not very much. When he was in dental school, he even told me that. He's more engaged with with dentistry now because he's ENT, so he has to work with oral surgeons and also the dentists. But what I do want to say is this. Okay, when I was in private practice, my practice was primarily pediatric and also hospital dentistry. So I did get a chance to work with the physicians in my area. And it was a small rural town, up in Northern California. I actually did go to the medical society, in my area. And where I am right now in Oakland, I have attended, the medical society meetings here. So what I would encourage you to do is that the physicians don't know what they don't know. And I think it's probably our job at this time is to reach out to them, educate. The pediatricians are great, but the family practitioners and also the OBGYNs, they may not be, as up to date. I have gotten a lot of referrals from pediatricians, not just within my agency, but also from outside, of Asian Health. So I think that pediatricians are probably our best friends at this point in time. So I would probably reach out to them first. And then from there, you can go to family practice, because I do think that the new generation is getting a different message, when it comes to integrated healthcare. I think they do want to know, about what's going on. And they have been trained not on dental, but I think on the concept of integrated healthcare. So that would probably be my best advice at this time, is to reach out to the medical professionals, and talk to your patients. I probably, on your medical history form that you use in your practice, there's probably a line that asks who's your physician, and not just who's your former dentist. Who's your physician. Reach out to those to those physicians.
So Kathleen actually has quite a few great points in that one question where she talks about it. Believes it's the future, but distant future. A great point about trying to connect with the medical side. Do you have any suggestions on not necessarily who, but like best practices? What's worked well when you do reach out, and what's the conversation look like? What's the level of interest, if any?
My experience, having worked with a number of primary care networks outside of community health, and I'm going to take hospital networks because a lot of those are driven actually by insurance companies, such as Kaiser Permanente, where they build their own facilities as well, is that they've been very good at handling all kinds of primary care, from behavioral health to medical to physical therapy and all of that. And now they're really starting to identify that their big gap is dental. And they're looking at how do they incorporate dental services into their network. So first, it's an opportunity. But secondly, when you're looking at these models, I'm seeing them willing to buy a software that is an interoperable software that they will put their contractors on. So for a DSO or a practice to go to a hospital network and say, talk to them about what the potential is for contracting with them, and sharing patient information in such a way that it helps them manage their patients, that may also be an opportunity. And I've seen that already in several states in the West, from Washington to Oregon, California, even here in Utah, where I live, and in Idaho, where these hospital networks are really starting to go, we've got to put dental in here. And rather than build their own facilities, it makes a lot of sense to contract with providers who are already out there, experienced, set up, and then make that connection in sharing patients and sharing patient information for effectiveness.
Absolutely. Great point, Andrea, points. Scott has an interesting point here / question where he talks really about, what does reimbursement need to look like in order to promote proactive care and really promote integrated healthcare. So he does make some good points about how the way dentists are compensated for things like varnish, and just what needs to occur to really almost kind of force medical and dental to work more closely together.
Well, there are a couple of areas that I think we're going to start to see changes being driven from the insurance industry. Once again, because they're spending so much now on inappropriate care. Let's take, for instance, a toothache in an emergency room. That's a $3,000 inappropriate treatment. I mean, you give an antibiotic, maybe a pain med, that doesn't solve the problem. But that's very expensive, and insurances now are really evaluating this. And I think it takes a united voice. And I think this is where we go to the ADA, other organizations, and start to have that conversation with insurance companies about seeing dentistry differently. You know, it was back in the 1830s when dentistry was separated out from medical, and we need to get it back in. But this is where getting organizations that are representative to really start to have these conversations on the fact that it's very cost effective, as Huong said, to do an A1C in a dental clinic. The patient is already there. They've been screened. The screening indicates that it is worthwhile. That patient is being caught before they become an acute hospital situation. So that's one really important aspect, is we've got to get representative associations really starting to craft and carry that message.
Yeah, and I think, ADA is one place, that we could work with. But also, the vendors. I mean, you guys will have to do something about it as well, and really, so the ADA needs to really work with the insurers, to make sure that things change, because the practices have changed, but the billing mechanism has not changed. So there's still a lot of advocacy efforts that need to go into this whole thing, because everybody talks about integrated healthcare. Everybody talks about, how we can improve, patients' health outcomes, but no one wants to pay for it. And then, and so ADA actually has they have developed a lot of codes for us to use now, even COVID testing and hemoglobin A1C tests and all that, but will the insurers pay for it? So I think that's something, that's still really lacking, very behind. So I think we need to work on that as well. But I do also think that, if the vendors can really, improve or somehow communicate with each other so that HR 7 is, in fact, does work, to establish the integration bridge. I think that's also important. I think the dentists are very open to doing these things because we know we are part of the healthcare team. The physicians, as I said earlier, are at this point in time are probably more open, especially the younger generation. CODA, the body that accredits, dental schools, also places an emphasis on interprofessional, training, in dental school, and medical school is also, under that same pressure. So I think, in the near future, there will be more communication, but we also have to get out of our comfort zone, and start not just thinking out of the box, but doing things out of the box. You
Yeah,
know,
that's a great point, Dr. Lee. That actually
uh,
ties into a couple of questions that we have. So there's a question that came in, so how do you really start, right? Whether you're a DSO or whether maybe you're a small group, what small steps can a group practice start to do to introduce total health to their patients? And then maybe we can even build on that question, like the part two of it would be screening tests. What would you look at as like, hey, these are the 3 or 4 really important screening tests that we should be doing in a dental practice, and we can do. So it's a two-parter. We'll let you start, Dr. Lee, and then Andrea can kind of fill that one in.
Yeah, this is right up Honey's alley.
well, I don't, okay. So, I can't really, I mean, again, I'm fortunate that I'm working at a community health center where I have all of these disciplines, under one roof, right? For those who are in private practice, like, either solo or DSO group practices, I think one of the first things, if you're not doing it already, is really, check your patient blood pressure anytime they come in, not just once a year, but at every visit. It doesn't really take that long. And if you notice that, they have hypertension, make the referrals and get a few local medical providers, or get the physicians that most of your patients go to. You can also ask, on our dental history form, we ask the parents about their children's immunization status. Are your children, are your children's immunization up to date? And if they say, oh, I don't know, no, yes, then, we have a script. I mean, like, we know when, it's easy to find. You can Google it and it will tell you, at what age certain, the patients will know, the children will have to get their immunization. And if they say they don't know or whatever, then you can take that time to educate them and maybe make the referrals to pediatricians. BMI. Okay, we do sedation services at Asian Health Services, and therefore it's important for us to know how much the patients weigh. Okay, so we just bought a scale, it's not that expensive. So we measure the height and also the weight, and we get the BMI on our patient. We enter that into a record. And if the BMI is high, our record would pop up an alert, BMI is out of range. So we can just show that to the patients in our treatment plan presentation, and so just those are the things that I don't think take a lot of time or a lot of resources. And just the fact that you show your patients that you care, your BMI is out of range, your blood pressure is really high, and I see that you're not on any medications. Maybe you should be seeing, your physician, and who's your physician? I can write a note to your physician. So those are the simple things that I think private practitioners can do, at the get-go, before you actually go into, conducting tests and all that. Or you can do this, just a screening like I do, how I started. And that was just use the American Diabetes Association survey and see if the patient score 5 and higher, then, talk to the patient, say, what, it shows here that you may be at risk for diabetes, please go see your physician. And if you need to, I can make a referral, and that's how you establish the relationship with their physician. But at the same time, it shows the patient that you care. And I think the patients know that you care. Then that trust, between you and the patient just doubles, just right there by that one simple survey.
Excellent. That's again some great tips, some good points. Looks like we have Lydia agreeing with you in the chat area. My experience from all perspectives, private practice. And then the chat disappeared on me, but it looks like we have agreement there. So
Okay.
that's good.
Well, thank you.
Yeah.
Yeah, just do it. I like that.
So we do have another question here that ties in. So we have a live question, and then we have one that came in earlier. So they really tied together. Again, you see these themes, right? Similar questions coming up regarding getting payments or reimbursement on quality outcomes, right? So, based on the outcome versus the procedure. What's your experience like in dentistry? And then what are you seeing, Dr. Lee, on the medical side, which seems like it's definitely more focused on outcomes right now versus the procedure. And dentistry still seems to be focused on procedure.
Yeah. Well, dentistry is decades behind medicine. And I hate to say that. I hate to admit that, because I always think that we are just pioneer, But when it comes to billing, when it comes to quality measures, I think we are way behind. But there are initiatives that are going on. I don't know about your states, but I know in California, we are in discussions of pay for performance type of reimbursement. California had what we call a dental transformation initiative, where we get actually paid, if we could bring the patients back in for exam, for preventive measures. And we've been doing this for about 5 years now. Okay, this is actually coming into our 6th year, actually, I want to say. Okay, started 2015. It's called Dental Transformation Initiative. So for those of us who have been able to bring the patients back in for cleaning, for fluoride, and all that, we got a bonus from Medicaid program. And this applies to actually all practices, not just public health clinics now, DSOs, private practices, and the state has paid out millions and millions of dollars. So I think I have the feeling that the Medicaid system in California is going to use the data, towards some sort of pay for performance, plan in the future. And I also think that the private insurance plans will probably follow, because they could see the value in the cost savings for the patients when their medical conditions are being managed under control, that they're more I think that they're able to to establish some cost savings. So I mean, it's long overdue, and it may not be happening anytime soon, but I see the trend. And I've seen that in California, for, like I said, for the last 5 years, many dental practices have been paid incentive payment, for just bringing the patients in, for additional, preventive care, if they could just see, so there's been an increase in the visits, and also the service in preventive. So I, it's long overdue, but I do think that it is coming.
Well, we see the Federal Centers for Medicaid and Medicare already driving that with how they're reimbursing for certain kinds of medical care, that there are bonuses or extra reimbursement paid for healthier outcomes of patients. And it seems like when CMS does that, private insurances start to pay attention. They start to look at the data and see whether or not it's working, and then that's how it gets adopted. So we're seeing that here, but like I said, that probably means 5 or 10 years before it really hits dental. But that, as that trend is happening in medical, sooner or later, it's going to ripple on down or across.
So we've got a couple minutes left, which I just want to thank everybody for joining us. I do have, I did want to ask this last question because a lot of the audience are group practices, DSOs. It's Andrea and Dr. Lee, you can certainly chime in as well. What are you seeing in the group practice DSO space as far as some integrated healthcare being provided now? I mean, I see Pacific Dental's doing some creative things. You know, you have Steve Thorne talking about the oral systemic connection. You know, there's a lot of talk about that. I see with Aspen Dental, they also have an urgent care clinic, a group of clinics that they own, and a lot of times they're co-located. So there is some referrals going on there. There is Westwind Integrated Health in Arizona, which is, I believe, it's so you have primary care and a dentist in one location. So I see a little bit of it. Any other examples that you see out there?
Those are actually the key ones, and some of them are doing quite well. Some are still really in their infancy as they're taking the step. It's rather interesting to see DSOs begin as the foundation for integrated care and add medical care, because the typical model is for the primary medical care to then add the dental care in. I do think we're going to see more from like Walmart. Walmart is embracing providing primary care and integrated care and in their settings or next to their settings. I still think most of it is going to generate our primary medical care, but in doing so, they really do need to have partners. So to me, focusing on what your expertise is, and you know, to become a DSO, you've already demonstrated expertise, not just in clinical care, but in your business structure, that you're really well positioned to be able to partner with a primary care organization of some kind to provide additional dental care. I even know of group practices that are contracting with community health centers to provide the dental care and getting on their platform, because there are places where community health centers don't feel qualified to be able to manage dental themselves, but they want to have that service for their patients. So contracting with an organization that has experience makes absolute sense.
Yeah, and I want to say something too about DSOs. DSOs are in great position to have great influence in a lot of legislative proposals, because you guys are big groups of practice. You have, you have the numbers. Okay, so I think that you can definitely have big, strong influence, in this whole movement. So I would encourage you to really, speak up, stand up, and really, let the insurance know, what is important to your patients. After all, it is the patients, and they need the patients just as much as we need the patients.
Thanks, Dr. Lee. I think on that note, we kept you an extra minute, so I think what we'll do is we'll just wrap things up. So thank you, Dr. Huong Lee. We appreciate you joining us today. Andrea Hight, thank you, and Henry Schein One for being a part of this. And thanks everybody for listening. It's really, I feel like we're just really at the beginning of this integration. And it's exciting. There's a ton of questions. We didn't get through all of them, but I think we got to most of them, which is actually pretty impressive given we had an hour. So thanks to both panelists. This recording will be available at groupdentistrynow.com. You will get an email and it'll link right to that recording. Also, if you have any questions, you can see we have Dr. Lee and also Andrea Hight's email addresses here, so feel free to reach out to them or myself. And again, thanks everybody for joining us here at the Group Dentistry Now DSO Study Club. Until next time, I'm Bill Newman. We appreciate your time today.
Thank you. Bye.
Thank you.
Bill, mine has .com at the end of it, and it's missing my email.
Okay. Very, very good. Yes, henryschein1.com. I missed that. Thanks, Andrea.
Bye.